Examination findings. The vitals on the presentation were he was febrile. The BP was the systolic was recordable at 60 mmHg after fluid resuscitation, and we started him on the inotropic support. His BP was around 100/70, and he was tachycardia, and his SATs were maintaining over the room air. On auscultation, on respiratory system, the chest was bilateral symmetrical, and we noticed the basal crebs, inspiratory basal crebs, and rest all examination findings were normal. This is the X-ray on the day of presentation, which was showing normal. And on routine blood investigations, we found the HP was low and thrombocytopenia with platelet count of 15,000, and his TLC count was around 8,400, and deranged RFT and LFT function tests. His urea was elevated and creat was around 2.5. His bilirubin was around 11.1 with moderate elevation of the liver enzymes. And also the CUE was showing 2+ albumin, suggestive of proteinuria with plenty of RBCs. And as a routine part, we screened the fever profile. We have sent for the smear for MP, dengue serology, and RT-PCR for COVID-19, which was turned out to be negative. And his serology was also negative. On presentation, ABG was showing severe metabolic acidosis. In the ultrasound findings, the liver and spleen were normal in size, and ECG was normal. So with the clinical presentation of fever, myalgia, shortness of breath, nausea, vomitings, and on general examination findings of conjunctival suffusion, jaundice with pallor, and on routine blood investigations, which was showing deranged RFT, LFT with thrombocytopenia, anemia. So we thought the on initial presentation, the patient was in shock, which is considered septic shock with multi-organ dysfunction. The problems of AKI, acute liver failure, and anemia and thrombocytopenia. So we thought one of the DD could be the leptospirosis in this case. So these were the problems in this patient. So we initiated him on adequate fluid resuscitation and started on inotropic support. And in view of empirical antibiotic therapy, in view of for leptospirosis, we have started him on ceftriaxone and doxycycline. These are the course of events. On the day 2 of his presentation, he was conscious. No fever spikes were observed. His BP was maintaining on inotropic support. And in view of decreased platelet count, we transfused 1 unit of STP. On the day 3, these were the X-rays, day 2 X-ray. On the day 3, patient was complaining of cough with blood in sputum, and he was also complaining of increased shortness of breath on the day of when compared to the day of presentation. And X-ray is also showing bilateral opacity in the lower regions. In view of and his saturations were not maintaining on the room air, and he became very tachypnic. So we planned for elective intubation on the day 3. The post-intubation X-ray, and also after intubation, we noticed bleed coming from the ET tube while suctioning, and his coagulation profile was